have the honor to invite John Puskas to the stadium. John is the was the chief of cardiac thoracic surgery in Emory, moved to New York, and now he is the chairman of the Department of Cardiothoracic Surgery in Mount Sinai and Beth Israel. He is the chair of the International Relations Committee of the STS. He is the PI on the Onyx trial that we'll present in this afternoon and in many other FDA trials. He's a great person, great surgeon, must be a great surgeon, but he's a relative of the famous Puskas soccer player from Hungary. Puskas, yeah. So, John.
Thank you, Gil. It's a great privilege to be here. My wife, Jane, and I have genuinely enjoyed our trip here to Israel. It's been a great pleasure, especially to be hosted by my friend and colleague, Erez Sharoni. To tour the northern part of Israel on our first day and then to see parts of Tel Aviv more recently. It's been a wonderful event. We look forward to the rest of the week in Jerusalem. I follow two brilliant speakers, Dr. Williams and Dr. O'Gara, who both delivered wonderful lectures on very broad and impactful subjects. I was asked to address a much more narrow segment of the cardiovascular spectrum, and that is to say, hybrid coronary revascularization, which is, I think, a genuine and legitimate and new treatment paradigm for a selected subset of patients with coronary artery disease. These are my disclosures. Hybrid coronary revascularization comes onto the field in the setting of new insights into the best therapies for complex coronary artery disease. And those insights have come from multiple important prospective randomized trials. They've taught us that beta grafting, for instance, prolongs life, that coronary bypass in general may outperform PCI for specific patients with more complex coronary artery disease. We've learned that radial arteries are usually better than veins, that off-pump bypass might be better than on-pump bypass, but only in specific centers and with special expertise. Perhaps that minimizing or avoiding aortic manipulation will reduce risk of stroke. There is a movement towards more arterial grafting with the goal of providing patients with longer benefit. And hybrid revascularization seeks to offer a combination of multiple arterial grafting with minimizing the aortic manipulation for a selected subset of patients. So what is hybrid revascularization? It is the planned, as opposed to the unplanned, combination of surgical grafting and PCI. I think that all of us surgeons will acknowledge that occasionally we have an unplanned combination of surgery and PCI. This is the intentional combination of it. And in fact, it has been recognized as an alternative in our AHA-ACC guidelines. In this particular most recent 2011 guidelines, it's considered reasonable as an alternative to multivessel PCI or coronary bypass traditionally in an attempt to improve the overall risk-benefit ratio. What is minimally invasive coronary bypass? We have felt that this is best defined as avoiding a full sternotomy, avoiding a cardiopulmonary bypass run, and that it may be single or multivessel. The concept of hybrid revascularization rests on the realization that the internal mammary artery graft to the left anterior descending coronary artery is probably the most durable treatment for coronary artery disease of the LAD, and that patencies may exceed 90% at 10 years and even at 20 years. It's also, frankly, a recognition that failure rates of vein grafts and drug-eluting stents to non-LAD targets may be approximately equivalent, at least for some coronary arteries and lesions, and for some veins. That's to say that there are PCI-friendly coronary artery lesions and there are cardiac surgery-unfriendly veins. If we choose to combine the positive features of both PCI and coronary bypass, we may achieve a better durability and a lesser invasiveness, and that's the goal of hybrid therapy. So I'm going to show you two cases of hybrid revascularization for two different types of coronary artery disease. The first is an 80-year-old gentleman who is active and presented with a non-ST elevation MI. He was diabetic and had some renal insufficiency, but was not dialysis dependent. His troponin was relatively low, and he was taken promptly to the cath lab. The left coronary injection shows a tight proximal LAD lesion. And you can see that that lesion is relatively unfriendly for PCI. The right coronary lesions are perhaps a little more friendly for PCI, and the distal target in the right territory rather less friendly for coronary bypass. Whoops, that should show us. So that's not animated, it seems. But this is imagine, if you will, moving limbs of a robotic instrument harvesting the left internal mammary with extraordinary skill. And then imagine, oops, someone's helping me here. This is Deus Ex Machina. In any case, we'll proceed to the next slide. So the anastomosis may be performed through a very limited skin incision, approximately 3 centimeters, without significant rib spreading and certainly no rib division. We're going backwards. Please just go ahead and advance the slide past that surgical image. There we are. And we're left with incisions that look like these. The patient's head is to the left and the feet to the right. And you can see the left breast and trocar sites. This is a very limited invasion and accomplishes an internal mammary artery graft to the LAD. This patient was discharged home on day 3 and came back to the hospital a month later. We first, my good friend and colleague Henry Lieberman, injected the internal mammary graft, documenting its patency. And then he went to work on the right coronary artery, achieving a very nice result. So it's an 80-year-old man, presents with a myocardial infarction, has a surgical intervention, goes home in 3 days, comes back for a day, a month later for PCI. That's a nice outcome for that gentleman. Case number 2 is a much younger man, a 57-year-old laborer, also presented with a non-ST elevation MI. And his cath showed multivessel PCI, including left main disease, but without right coronary stenosis. This is a young man who had a strong family history for coronary artery disease. And here is his left coronary injection. You can see a distal left main stenosis and independent lesion in the proximal LAD. A better view of the distal left main lesion there. So he underwent robotic-assisted internal mammary grafting to the LAD and a subsequent PCI of the left main on postoperative day number 1. This, of course, is preceded again by a control angiogram of the internal mammary graft, demonstrating its patency. And then Dr. Lieberman is able to perform a protected left main angioplasty, stenting the left main into the proximal circumflex and jailing the ostium of the LAD intentionally. And he ends up with a beautiful result in good perfusion of the LAD, the circumflex territory. So again, he was discharged home on post-op day 3 and back to work in 2 weeks. This is his chest on the left, a different gentleman on the right. These are typical appearances of a robotic bypass 2 weeks post-op. And this is the same young gentleman 4 weeks post-op. So we developed coronary anatomic indications for hybrid revascularization that really rest on the notion of bypassing surgically the lesions of the proximal LAD and managing non-LAD lesions with PCI. So an ostial LAD stenosis, especially one that might be in a restenosis situation for the proximal LAD, or a very calcified ostial or long proximal LAD lesion. And of course, we're hoping to find lesions in the non-LAD targets which are amenable to PCI, type A lesions. I think that an isolated distal or bifurcation left main stenosis is an ideal case for a hybrid revascularization, because we can then have a basic conversation with our cardiology colleagues. Why would you do an unprotected distal left main stent when you can in fact do a protected left main stent after an ITA is grafted to the LAD? We looked at our outcomes comparing hybrid revascularization with beta grafting and CETA grafting at Emory, and this was presented at STS this year. We looked at all the patients in our Emory STS database over a 10-year period, totaling about 10,000 patients, excluding those that you would expect, and then generating a study population of 8,500 patients who comprised 300 patients with hybrid revascularization, about 875 with beta grafting, and about 7,000 with CETA grafting. As you can see, the patients, of course, were in fact quite different, with the highest risk patients being treated with CETA grafting. The beta patients tended to be younger and have less lung disease. We had a similar degree of left main stenosis in the beta and CETA, and less, of course, in the hybrid revascularization. The predicted risk of mortality in all these were low, but higher in CETA than in beta or hybrid, as you see here. Outcomes for MACE were not significantly different between groups, either for all-cause mortality, MI, or stroke. For in-hospital complications, there was a benefit of hybrid revascularization versus beta or CETA, and ventilation longer than 1 day was one of the ways in which hybrid revascularization commonly outperforms sternotomy procedures. Deep sternal wound infection, of course, did not occur in the robotic patients, as there was no sternotomy. Bleeding events and any blood transfusion were less common in hybrid cases than in either sternotomy procedure. And discharge in less than 5 days was more common in hybrid revascularization than either beta or CETA. We found that hybrid revascularization stood up over time, and that survival was not different between CETA and hybrid, or between hybrid and beta. But in fact, if we compared our beta versus CETA group, as we have done in multiple previous analyses from our database, we found that beta patients lived longer than CETA patients. And in fairness, there seems to be a trend towards longer survival in beta patients than in hybrid patients as well. So hybrid revascularization is an interesting new therapy, and it's one that has not been subjected to a prospective randomized trial, but it has been studied by the Cardiothoracic Surgical Trials Network with the goal of understanding how hybrid therapy is being used in the United States and whether we might be able to do a randomized trial. So this was an observational trial. I had the privilege of presenting at TCT in October 2013 on behalf of our colleagues. This was a prospective cohort observational study at 11 U.S. centers, and it was intended to inform the design of a randomized trial, for which we have just recently submitted the NIH grant, and we are waiting eagerly to hear whether we may be funded. But the purpose of this observational trial, which was in fact funded by NIH, was to establish whether a larger prospective randomized trial was feasible. And so we studied the behaviors of physicians, surgeons, and cardiologists as they treated patients who might have coronary anatomy eligible for hybrid revascularization across our country. Specifically, we examined about 7,000 angiograms at these 11 centers over a 3-month period. We found that about 4,000 had significant coronary disease, and about 500 patients were anatomically eligible for hybrid revascularization, meaning they had proximal LAD disease and limited other disease. We looked at those who were clinically eligible for hybrid revascularization, defined by agreement between a local surgeon and cardiologist that the patient could have hybrid therapy. And then we studied those patients who were eligible and who either had hybrid therapy or PCI. And this was not randomized, but rather observational. So cohort B are the patients that were eligible for hybrid therapy and had either hybrid therapy or multivessel PCI. So I show you the centers that were involved in our trial because you'll see that there's a tremendous difference in the way different centers approach these similar patients. Look at Columbia University, the second row. Among 26 patients who had hybrid eligible anatomy, 23 had PCI and 3 had hybrid therapy. If you look at Emory University, among 83 patients who had hybrid eligible anatomy, 79 had hybrid therapy and 4 had multivessel PCI. There were some that were more balanced. For instance, Ohio State, it was 9 and 6. So it's all over the map. There was clearly no consensus between institutions how these patients with hybrid eligible anatomy should be managed. These patients had a variety of types of coronary artery disease. Most had two-vessel disease. A few had left main disease. The large majority had proximal and a few mid-LAD stenoses. And notice that the syntax scores are low. We're not talking about multivessel disease and diabetics being suitable for hybrid revascularization. Rather, we're talking about, is a patient who has a lesion in their mid-right and the ostial or proximal LAD better treated with 2 stents or a LITA and a stent? We did, in fact, study how the procedures were performed. Most commonly, patients had the LITA to LAD grafting performed and then a PCI, but a fair number had the opposite. It was reversed. Some had single procedures, meaning the PCI and surgery were performed in a hybrid operating room at one setting under anesthesia, and many had 2 settings. Among the surgical procedures, endo-ACAB includes robotic bypass, and a little over half of patients had that approach. Traditional thoracotomy mid-cab was performed in about 20%, and about 20% of patients had totally endoscopic robotic bypass. Interestingly, one of our centers chose to do sternotomy for the off-pump portion of this operation. Statistical analysis was accomplished in standard techniques utilizing preoperative variables, propensity score matching, and Cox progressional hazard analysis. And this is the take-home slide from this observational trial. That is to say that over the first 12 months of observation, major adverse cardiac and cerebral events were not different between patients who had hybrid eligible anatomy and received hybrid therapy and those who had hybrid eligible anatomy and received multivessel bypass. However, after 12 months, the curves appear to diverge somewhat. The numbers are small enough that neither curve is statistically different from the other. But the fact that it was essentially equivalent over 12 months gives us hope that surgeons and cardiologists will feel it is ethical to randomize, and the fact that the curves seem to diverge after 12 months may indicate, in fact, that the benefit of LITA grafting to the LAD is important, and that perhaps hybrid therapy has some advantage over multivessel stenting in these particular patients. So we thought this constituted equipoise for a more rigorous comparative effectiveness trial, and we have, as I mentioned, submitted an NIH grant on behalf of 47 centers in a large network in North America. We hope that this will be funded. We look forward to hearing from the NIH in about 3 months. And if it's funded, we'll certainly let you know, because it'll be a very exciting enterprise moving forward. Finally, we look forward to a meeting that I'm going to put on with David Taggart in New York later this summer to do a deep dive into all things related to coronary surgical revascularization. I know that this will be of interest to many of you in the audience and look forward to your attendance. Thank you.